Go.
Hi, I'm Naja Wilson, and I'm going to be performing the observation.
I am observing for visible edema, moles, scars, and other factors that may affect the scope.
Okay, I'm doing the instrumentation part, and for the instrumentation, you want to be sure that it's on and that it's set to medium, and the sensitivity is medium, and the probes are narrower for the cervical spine and wider for the thoracic. And tips for the probe is to have a good seal, slightly depressed on the skin, or a slight depression of the skin around the probes. Probes stay perpendicular to the skin, and probes stay centered over the spine. A break is fairly quick over and back movement and occurs within a short distance, about 1 segment worth, and must be repeated 3 times and is marked on the trailing edge of the hot spot. Now, so you go up on the cervical spine, and then down T2, and down from T2.
Every time, because I've had her in most of my lives, every time you touch her skin, it's just like immediately, no matter how hard.
And there's a hot spot, so we go 1, 2, 3, trailing edge. Okay, I'm going to be doing the static palpation part of the exam. First, I'm going to be assessing for edema, and with my fingers on either side of the spine, I'm just going to be looking for bogginess. Okay, and then to assess the pain on palpation portion, usually pressure at the inferior aspect of the spinous process will induce pain, and I'll ask my patient, do you feel any pain with that?
No.
Okay, and then for the SI joint, tenderness at the upper joint may indicate a PI, and tenderness at the lower joint will indicate an AS, and tenderness throughout the whole joint will mean an EX, and no tenderness with deep inguinal pain can indicate an IN. I'm going to be doing the motion palpation for the occiput. So for laterality, I'm going to contact the mastoid and C1 TVPs, and I'm going to laterally flex the head. If it doesn't close down, it's going to be lateral on that side. For P to A and AP glide, I'm going to use the calcaneal portion of my hand to contact the patient's posterior superior to the ears. And for P to A glide, I'm going to tilt the head and spring for, or P to A glide, I'm going to be feeling for springy in play, and lack of springy in play is going to indicate a PS occiput. For AP glide, I'm going to use the hypothenar on the occipital ridge and roll the head to the right based on the lateral tilt, right or left based on the lateral tilt, and I'm going to feel for springy in play on the A to P glide. If there's lack of, that's going to be an AS occiput. For P to A rotation, I'm going to contact the mastoid and the TVP of C1, and I'm going to rotate the patient's face away from the contact side, and I'm going to feel for the mastoid to move away from me. If it moves forward, or I'm going to feel for the mastoid to move forward. Lack of movement is going to indicate a posterior side of listing. I'm going to be doing motion palpation of the atlas. So for laterality, I'm going to contact the TVPs of C1 and C2 and laterally flex the head. And if the TVPs don't close down, the atlas is lateral to that side.
For superiority and inferiority, the patient's going to stand and close their head and nod. So I'll have you stand. Okay, if you'll close your head and nod a few times and stop where it feels comfortable. Okay, so a high chin is going to indicate an AS and a low chin is going to indicate a PI. Go ahead and have a seat. Okay, for posterior and anterior, we're going to contact the posterior arch of the TVP of the atlas, and we're going to rotate the patient's face away from the contact and push A to P on the atlas. Restriction indicates posterior atlas. Okay, I'm going to be doing motion palpation for the cervical spine. So for posteriority, we're going to flex and extend the body while feeling tips of the spinuses between our fingers. If they don't separate, then that indicates a posterior. For rotation, we're going to use our chiropractic index finger and contact the segment, and our index finger and our ring finger, I did that backwards, our ring finger and our index finger to contact the segments above and below. And we're going to rotate the patient, and if the segments do not separate, then the side of rotation is the side of listing. So if it's right side not separating, then it's going to be a PR. For lateral wedge, we're going to contact the spine above and below and at the involved segment. The patient will flex left and right, and we should feel a curve. If the spine is flat, then the open wedge is to the side that the patient is leaning. Okay, I'm going to be doing the motion palpation for the SI joint. I'm going to start out figuring out which side is the involved side by doing the twist and bend. I'm going to start out with the twist by contacting the SI joint on the opposite PSIS. On the opposite PSIS and sacrum, and I'm going to take the ipsilateral shoulder and rotate back. This should produce movement in the SI joint, and if not, then I'm contacting the subluxated ilium. For the bend test, I'm going to place both thumbs on the PSISs and have the patient bend forward. And the side that moves up is the subluxated side. If there is a wobble, then that seems to indicate a sacrum. Okay, I'm going to be assessing the PI and AS aspects of the SI joint. First, I'm going to observe the bottom edge of the glute, and a high glute is an AS and a low glute is a PI. And then for the mechanical portion, I'm going to do the high knee test. I'm going to place one thumb on the PSIS and the other thumb on the center of the sacrum around S2. I'm going to have the patient raise the leg of the same side. So go ahead, raise your left leg and down. Okay, and the thumb on the ilium should move posterior inferior, and if not, then that indicates an AS ilium. And then I'm going to have the patient raise the opposite leg. So raise your other leg and down. And the thumb on the sacrum should move inferior. If not, then that would indicate an PI ilium on the involved side. Then I'm going to check the glute widths at the gluteal cleft. And a narrow glute is an EX and a wide glute is an IN. Then I'll have my patient sit down. Check the EX. For the EX and IN portion, the mechanical portion, the patient is seated, and I'm going to place my fingers on the SI joint, and I'm going to take the involved leg and swing the knee medially. The PSIS should open away from the sacrum slightly. If not, then that is an IM ilium. Then I'm going to take the knee and swing it laterally, and the PS should close towards the sacrum slightly. If not, then that is an EX ilium.